Um, Welcome to the Norton Infectious Disease Institute grand rounds today. We have Kasie Hoover and Dr. Chris Bryant, and they are going to talk to us about latent tuberculosis infections. Um, Kasie and Dr. Bryant, take it away.
Okay, hello everybody. Oh, and it's not wanting to go to the next slide. One second.
Well, hello, everybody. While Kasie begins working with the slides and getting them to display, some of you may be wondering, why latent tuberculosis infection? Why is that our topic today? This is an important public health problem. It's estimated that up to 13 million people in the US have latent TB. We don't quite know how many because LTBI is not reportable in every state, but it's an important public health problem. Um, Kasie, do you want to introduce yourself and
Yeah,
about what you do?
absolutely. So my name is Kasie Hoover. I am a nurse practitioner by training, but an infection preventionist at heart. So I have been with the Norton Children's Medical Group. I'm their infection preventionist for the last year and a half. And I have really just dove into a love for public health, a love for education, and most definitely a love for infection prevention.
Thanks, Kasie. I'm Chris Bryant, Kasie's partner in crime for this grand rounds. It's an honor to be asked to do this with her today. I'm an infectious disease doctor by training. I work as a healthcare epidemiologist and as the associate medical director at Louisville Metro Public Health and Wellness. And occasionally I get to pretend to be an infection preventionist because that's where my heart is. So, we are going to essentially present to you today latent TB through an infection prevention lens. You see our commercial disclosures on this slide, none of which are relevant to today's presentation. But we should disclose that we could spend hours talking about LTBI. We only have less than 30 minutes. We could spend days talking about active TB, so we certainly can't give you an overview of that. This is really going to be latent TB through an infection prevention lens. And for those of you who are joining from Southern Indiana or from adjoining states, apologies that this will be a bit Kentucky-centric. Back to you, Kasie.
Okay, so we have a couple of cases we're going to go through. If you guys want to put your answer or what your thoughts are in the chat. So a 12-month-old presents to your office for evaluation after her father is diagnosed with active TB. She had no symptoms and her exam is normal. Which diagnostic test would you order? A would be a tuberculin skin test or a TST. B would be an interferon gamma release assay, or C, would you say either one is fine? So give everybody a minute to kind of think about that and put your answer in the chat.
So Casey's such an interesting case. The audience is probably zeroing in on the fact that Kasie and I are both pediatric clinicians, and so we really like pediatric cases. Uh, Now, just from a medical standpoint, a 12-month-old exposed to active tuberculosis is at risk, and she has to be tested. If she gets infected with TB, she's at risk for developing TB disease because of her age, so it's important to test her. Interesting chat responses, Kasie.
Okay. So, Dr. Bryant, can you tell us a little bit more about this test and how it works?
Yes. So, from the chat, we sort of had a split. Maybe a few more people recommending TST, some gamma interferon. Nobody said C, either one. which is super interesting to me. I will say, in the truth of the world, I think the most correct answer is either. Test is fine for a 12-month-old. We'll talk a little bit about that. But personally, as a pediatric ID physician, I would get a gamma interferon release assay or an IGRA. So let's talk about what those tests are. So IGRAs are blood tests that measure a person's response to the TB germ. And there are two different tests that are used. There is the quantiferon gold or the T-spot test. And they're very similar. They're both blood tests that measure immune responses to TB. So, Kasie, if we could, yes. As you can see, these are very, very similar. So we can go on to the next one.
I apologize. I accidentally hit that button too fast.
No, you're good. So how does the quantiferon test work? So whole blood is drawn from a patient, and then it is incubated with peptides that simulate TB antigens. The names of some of those antigens are listed on this slide: ESAT6, CFP10, etc. The important thing to know, you don't need to remember the name of the antigen, is that if in response to if the patient has been infected with TB, they will produce gamma interferon, and that can be detected and analyzed. So some of you may say, okay. So again, we're not detecting the TB germ, we're detecting the body's response. And are they recognizing the TB germ? So I told you my personal preference would be to do an IGRA test like the quantiferon for a 12-month-old who was exposed to tuberculosis. Some of the advantages are that unlike a TB skin test, this requires one visit. With the TB skin test, you place it, they've got to come back. As you all know, sometimes patients don't come back. It requires some skill to interpret the test, and the interpretation of a skin test is different depending on what your risk factors are. The quantiferon, you get a test from the lab. And so you take out the need to measure potentially the variability, but it's not perfect. So you got to draw blood, and in this case, draw blood from a small child. False negative test can occur. Remember, it takes about 8 weeks to develop an immune response to tuberculosis, and so maybe the test is performed too soon. There can be technical difficulties with the test. Maybe there is a problem with the specimen in transport. This is measuring immune response. So people who are severely immunocompromised might not respond. So that's another disadvantage. Another disadvantage is that there can be low-level false positives. So depending on how much gamma interferon is produced, the lab will tell you positive or negative. But when it's a low-level positive, sometimes you'll get an instruction to repeat it, and when the test is repeated, it's completely negative. There are some advantages, though, in addition to just one office visit. There is no cross-reactivity with BCG vaccine. And so in a person who comes from a place where BCG vaccine is given, this is the test to perform to find out if they've been infected with tuberculosis. Kasie,
So
we can go to the next
yeah.
slide.
So speaking of the results, often providers will get these in their end basket, and it's positive, negative, and the lovely indeterminate that everybody loves to receive. So can you talk a little bit about how these can be easily interpreted by someone providing care about what the testing results mean?
Yes. So if the test is positive, it means that tuberculosis infection is likely, unless it's a low positive. You might want to repeat that. If it's negative, tuberculosis not likely, but not entirely excluded. No test is 100%. And again, in people who are immunocompromised, they might not respond, or maybe there's just not been enough time to respond. The really challenging thing from the clinical standpoint are the indeterminate results for quantiferon or borderline for the T-spot. And, the first time I saw this, I thought, this patient's just a little bit positive. So that's worrisome. Doesn't mean that. It means the test didn't work and you just have to repeat it.
Okay.
All right. Now, anyone who answered our initial case might have been thinking that we were trying to be tricky by presenting you with a 12-month-old. Not so long ago, we did not do a TB blood test in kids under 5 years of age. And then the lower age limit came down to 2 years of age. And in the 2024 update of the American Academy of Pediatrics Red Book, this is the AAP's recommendations for infectious diseases. It says that you can do a quantiferon in a child of any age. So if we'd been talking 5 years ago, quantiferon wouldn't have been the answer, but it is now.
Yeah, that's super helpful. So we have another case. Again, if you guys want to put your comments in the chat, that would be great. So this case number 2 is an 18-year-old high school senior in a health professions program, and they're required to undergo testing for TB prior to starting their clinical rotation. We've all experienced this, right? A quantiferon test is positive, but her chest radiograph is normal. What is her diagnosis? And because of our technology issues, Chris, I'm too nervous to open up the chat. So you let me know when you think we're good to move on to the next slide. Give everybody enough time.
Well, so we have 3 votes for latent TB and a possibly latent TB. That's from Kristen Trudeau. I will say, I think, and that's from Jamie Barnett as well, another vote for potential or possibly, potential from Jamie Barnett. I think that is my favorite answer because I don't know that we have enough information quite yet to know what this diagnosis is.
Yeah, I agree. So this slide here talks about the differences between latent TB infection and TB disease. I think it's really interesting to point out how our medical language has evolved around this. So latent TB or TB infection would be different than TB disease or what many of us would know as active TB. So these patients present very differently, right? So you have these results back and you're thinking back to your visit when they were in front of you. And so some things that you may point out if your patient has latent TB infection or LTBI would be they don't feel sick. They're going to work, they're doing their normal activities, they have no symptoms, right? What's also interesting about this is that they cannot spread the bacteria to others. So the minute you call them and say, hey, we're worried about tuberculosis, that's probably one of the first questions you're going to get. Have I infected my entire family? What does this mean? So I think that's a really important when we're thinking about infection prevention and caring for the family as a whole to reassure them that with LTBI, they are not actively spreading the bacteria to others. People can have latent TB infection for years, right? And actually, they are at risk for developing TB disease. So patients that have untreated latent TB infection do pose a higher risk for developing TB disease, which is something that as a clinician, I did not realize. So I think that's a really important factor in the importance of recognizing these patients early, getting them treatment, and making sure that we're referring them to the appropriate avenues so that they can get this taken care of. So persons with TB disease or active TB, they feel sick. They may have night sweats. They have cough. They may have some weight loss. These people are able to spread this bacteria to other people. So in my infection prevention mind, this is definitely a higher acuity because we have to make sure that we're not spreading this, and this patient is in a vulnerable state that they can actively spread it. They have a large amount of the active TB germ in their body. They have a positive TB skin test or TB blood result indicating that they have this infection. And they also need treatment. It's really important that we realize and recognize that patients in both categories do require medical intervention.
So, Kasie, that's a great explanation. I think in terms of the case, right, the decision point is, does she have latent TB or TB infection? Those are TB infection is sort of the current term, or TB disease. And so she's definitely infected. She's got a positive quantiferon. She's got a negative chest X-ray, but we don't know much about her symptoms, and we don't know about her exam. So we need those pieces to really know for sure if she has just TB infection or she truly has TB disease.
Yeah, completely agree. That history and physical exam are very important. So, tagging on to that case, what are your thoughts? The teenager should be allowed to participate in her clinical rotation because people with TB infection can spread the infection to others.
Yeah, so while you're typing in the chat, we're happy to report to you that her physical exam was normal. She has no symptoms. You can put her firmly in the latent TB bucket. So now what do you do?
So, still talking about the same teenager, what are your thoughts? The teenager should be referred to the health department for treatment of LTBI. No, because she doesn't need any treatment. B, no, because I can treat her in my office. Or C, yes, because I do not treat TB.
Um, so Kasie, a fascinating question. Should we take them one by one? Should we go back to the last slide? What do you think? Are you going to let her do her clinical rotation?
I'm thinking yes,
Yeah,
absolutely.
I agree. Nobody wanted to take that one. Um, uh, uh, in the chat, we're getting a little bit of traction on the second question about treatment.
Okay.
And if we go to that slide, um, uh, health department, we've got one answer for refer to the health department because I do not treat TB, and one, no, she doesn't need treatment, even though she has latent tuberculosis infection.
Yeah, I think this is an interesting question, especially in my world of infection prevention and our resources within our community about how we can best get this patient treatment for her LTBI. So I think based on the prior slide, we do know, Chris, that she does need treatment, right? That's important. And I think it depends on the clinician's comfort level. I do see in my world that a lot of clinicians that work in primary care in the adult setting, they are comfortable treating latent TB infection, which definitely makes access to care a little bit easier, and takes some of the burden off of our health department.
Yes. So it is an interesting question. So this teenager has TB infection. She has the germ in her body. She has no evidence of active disease. She's not infectious, so she can go about her clinical rotation. But I would argue it's still important to treat her, because she's at risk over the long term to go on to develop active TB if she's not treated. The CDC estimates that approximately 80% of TB disease cases in the US result from progression of untreated latent tuberculosis. So I would say, yes, she needs to be treated. Now, where does she need to be treated? As Kasie pointed out, many primary care clinicians treat TB, latent TB, in their office. And we encourage people to do that. Only a handful of people with latent TB need to be treated by the health department. Individuals who come into the country as refugees, and are classified as B1 or B2 when they enter the country. So a certain class of tuberculosis when they enter the country based on their evaluation in their home country, they do need to be treated at the health department because they're going to need some very specific paperwork signed to complete their immigration process. Most other people with latent tuberculosis can be treated in primary care offices. Another exception might be a contact of an active case of TB. The health department usually likes to treat contacts of active cases. Others, like this teenager who was just discovered on routine screening, she can absolutely be treated in a primary care office. And one of our goals, if you said, well, I do primary care, but I don't want to do this, we want to show you that it's pretty easy. Should we go to the next slide?
Absolutely.
All right. So the CDC has a number of resources available. There are multiple options for treatment of latent TB, and this is one of the TB resources that outlines at a glance what the treatments are. When I started in infectious diseases a while ago, in 2000, I entered practice. We treated latent TB with 9 months of INH. Now you can see that there are multiple options, including a 3-month regimen that consists of isoniazid and rifapentine, also 3-HP. This regimen is given once a week for 12 weeks. 4 months of rifampin, daily rifampin, is also an option. We know that completion rates are better with the shorter course, and they are generally associated with less toxicity. The INH and rifapentine, as I mentioned, it's once a week for 12 weeks. If the health department is administering this, they often do it with directly observed therapy. You can prescribe this in your office, however, and it can be self-administered if you feel like the family will comply with that therapy. Why don't we go on to the next slide? One of the most common questions I get about treatment is, well, what about liver enzymes? Do I need to check baseline liver enzymes? We know that INH and some of the other medications may have a side effect of hepatitis. A good clinical practice is to tell the patients about side effects to watch for, including hepatitis. What does that look like? Belly pain, jaundice, nausea, and vomiting. But not everybody needs baseline laboratory testing unless they have one of the risk factors listed on this slide. Interestingly, hepatitis is not the most common side effect of 3-HP therapy. The most common side effect is a hypersensitivity reaction that looks like flu, and that only occurs in about 3 to 4%. All right, why don't we go on to the next slide? The CDC has a toolkit for primary care clinicians who would like to treat latent tuberculosis, and a conversation guide for healthcare professionals and for patients are depicted on this slide. All right, why don't we go to the next slide? We've got a bonus case for you. Kasie, take it away.
Okay, a 35-year-old man presents to the ICC with cough for what he reports has been happening for months, as well as night sweats and intermittent fever. His quantiferon is positive and his chest x-ray is abnormal. What are your next steps?
Some of you may be saying, oh, wait a minute, you said this was about LTBI. And this guy clearly has active disease. So we're going to get 3 sputum samples for acid-fast bacilli. Once specimens are obtained, he'll need to be referred to the health department to be started on therapy. In Kentucky, the health department treats all cases of active TB and only some of the cases of latent TB. But remember, we're talking about an infection prevention lens. So after all of that is done, what should happen? And yes, Dr. Frith, we'll give him a mask before we do anything.
Yeah, I think while we are doing all of those wonderful things, I think to stop and pause and a good reminder to contact your infection preventionist, use them as a resource. I think people are going to want to know this patient's coming in for their flu shot next week. Are they safe to come in? When are they safe to come in? How long do we need to keep them out of our offices? And do we have any risk to the other patients that we're seeing there?
Yeah, I think, that's one of the most common questions we get as the infection prevention team. A patient with TB, he was in the ICC, right? Are people in the ICC exposed? And so I'll put on my public health hat and say that the definition of who is exposed is often established in collaboration with public health authorities. A minimum time frame has not been established. But TB usually is not transmitted with transient contact. Within Norton Healthcare, we have used, as many other facilities do, a cumulative time frame of 8 hours of exposure. That seems random. Where does that come from? Well, it comes from the learning that airline passengers who are seated for greater than 8 hours in the same or adjoining row of a person who is contagious with TB are much more likely to be infected than other passengers. And so that's one definition that people use. But I will say that public health authorities can be very helpful in looking at specific situations. Does that 8-hour time frame make sense? Are there patients who are at really increased risk, or individuals who are at really increased risk, patients, other healthcare workers? We might use a shorter time frame. The other thing that you want to consider, and that public health will consider, is to say, let's just take a pause before we start trying to consider a lot of people in a healthcare facility exposed. Let's find out first if this person has infected anybody else in their immediate family, anybody they spend a lot of time with. And if the answer is no, nobody else in their family is infected, that means that there's really less worry in healthcare settings, work settings, school settings, et cetera. All right, in the interest of time, we can go to the next slide.
So the health department initiates treatment after appropriate sputum specimens have been collected and the patient is placed on home quarantine. When is he no longer infectious? His primary care office wants to know as he has an appointment for his COVID and flu vaccines coming up soon.
Is this a shameless plug for COVID and flu vaccines?
Maybe. We'll use those every opportunity we can get.
Yes. All right. So our final slide is next. We've put on this slide the criteria from the Kentucky Clinical Service Guide that is used to determine non-infectiousness in Kentucky. And so, basically, a person who is smear positive is considered non-infectious after they've been on therapy for 2 to 3 weeks. They've been compliant with that therapy, and their sputums are showing decreased numbers of acid-fast bacilli. That's the big picture. But you don't have to know that because the health department is following the patient, treating them, and they will actually give the infected individual a letter releasing them from quarantine and something they can show people to say, hey, I'm no longer infectious, and I can be out in the world again. So that is our whirlwind tour of latent tuberculosis infection. It's been wonderful to spend a few minutes with you today, and we're happy to answer any questions.
Excuse me, any questions from anyone? I did see one in the chat, but I think that ultimately it ended up being answered, the difference between the IGRA from the T-spot, but I think if I'm looking at that correctly, it was answered in the presentation. So we are good there. Anybody else have any questions?
Yeah, both blood tests for TB, they're both measuring gamma interferon that is produced. They have a different way of measuring the gamma interferon, though. One looks at concentrations and one looks at spots.
Wonderful. Thank you. I will say I got tricked on the TST for the 12-month-old. So guidelines change quickly or not so quickly. I don't know. It depends on how you're looking at it. So, all right. Well, thank you all very much and have a fantastic day.
You too.
Bye-bye,
Thank you.
everybody.
Bye-bye.